Hello everyone, how are you? Today I'll talk about a very important topic of hemodynamics, which is edema. So here's a figure of a very common clinical picture, a edematous lake. Okay, so what is edema? Edema is the excessive or abnormal accumulation of fluid in the tissues. Okay, we know normally the vascular hydrostatic pressure is nearly balanced by the plasma colloid osmotic pressure. So, what is the hydrostatic pressure and what is the plasma colloid osmotic pressure? Okay. Hydrostatic pressure is a pressure which pushes the water and salts out of the capillary into the interstitial space. Okay. And the plasma colloid osmotic pressure does the opposite. That means it pulls the water and salts back into the vessels. Okay, and there is a small amount of net movement of fluid into the interstitium. Then it drains into the lymphatic vessels, then thoracic duct, then ultimately returns to the bloodstream. So, these two pressure actually balanced, nearly balanced in normal physiologic condition. Okay, but what if the balance is disrupted? That means we can, let's say, hydrostatic pressure is increased and plasma colloid osmotic pressure is decreased or diminished. Then what will happen? It results in increased movement of fluid, isn't it? And if this net rate of fluid movement exceeds the rate of lymphatic drainage, then fluid will accumulate in the interstitial space, and these will be called edema. It occurs within the tissue, okay? But if a serosal fluid is involved, fluid may accumulate within adjacent body cavity, which is called effusion. For example, we can see a pleural effusion. Here, edema occurs in the pleural space. Fluid, we shouldn't say edema. Here, effusion occurs in pleural cavity or fluid accumulates in the pleural cavity. Okay, so it is called pleural effusion. Okay. Now, let's learn the pathophysiology categories of edema. There are 5 categories. 1. Increased hydrostatic pressure. 2. Reduced plasma colloid osmotic pressure. Number 3. Lymphatic obstruction. Number 4. Sodium retention. And 5. Inflammation. Okay. First of all, come to the increased hydrostatic pressure. What are the causes of it? Mainly it is caused by impairment of venous return. For example, in deep vein thrombosis, and generally it occurs in lower extremity. This impairment is localized. That means the edema is confined to that affected part only or lower extremity only. Okay, but there are some other conditions that lead to systemic increase of venous pressure. For example, congestive cardiac failure. So it is associated with more widespread edema. Okay. Okay. So, under impaired venous return, we can say congestive cardiac failure, constrictive pericarditis, ascites or liver cirrhosis, venous obstruction or compression, thrombosis, external pressure or mass, lower extremity inactivity with prolonged dependency. Okay, and there is another cause which is arterial dilation, and we can say heat and neurohumoral dysregulation dilates artery, and also the hydrostatic pressure is increased and edema occurs. Okay. Secondly, come to the reduced plasma osmotic pressure. Okay. So what causes this plasma osmotic pressure? Of course, it is caused by plasma proteins. And we know albumin accounts for almost half of the total plasma protein. So if there is inadequate synthesis or loss of albumin from circulation, then plasma colloid osmotic pressure is also reduced. Okay, for example, in liver cirrhosis, albumin synthesis is reduced, and we can also say in protein malnutrition, also protein synthesis is reduced. Next, we can say in nephrotic syndrome, okay, here glomerular capillaries are abnormally permeable. That's why albumin leaks into the urine. So plasma osmotic pressure is reduced, which leads to edema. And there's also another cause, protein losing gastroenteropathy. So these 4, protein losing glomerulopathies or nephrotic syndrome, liver cirrhosis, malnutrition, especially protein energy malnutrition, and protein losing gastroenteropathy. Okay. Okay, now next come to the lymphatic obstruction. If the lymphatic vessels are obstructed, then clearance of the interstitial fluid is impaired and resulting in lymphedema. We can say, for example, trauma, fibrosis, invasive tumors, and some infectious agents can cause this lymphedema. And a very good example is parasitic filariasis. Here, obstructive fibrosis of lymphatic channels and lymph nodes occur. Okay, and this may result in the edema of external genitalia and lower limbs. And it is so massive that it is called elephantiasis. Okay, and also, in breast cancer patients, they have to receive chemotherapy with radiation or may undergo surgical removal, which is associated with axillary lymph nodes. And in such cases, edema can also occur. So, under lymphatic obstruction, you can say inflammatory cause, neoplastic, post-surgical, post-irradiation, etc. Here's a figure of elephantiasis. Okay, just see how massive this edema is. Okay. Now come to the sodium retention. You know, salt always transports in company with water. Okay, so if salt retention is increased, we can say water retention must occur, isn't it? Okay, so intravascular fluid volume also expands, and which causes increased hydrostatic pressure. And there's also diminished vascular colloid osmotic pressure due to dilation. And finally, edema occurs. So when does this salt retention occur? When there is decreased renal perfusion or hypoperfusion. Okay, and what are the causes of renal hypoperfusion? One of the most important causes, congestive cardiac failure, and it activates renin-angiotensin-aldosterone system. And with this continuing worsening of failure and diminished cardiac output, the retained fluid merely increases the hydrostatic pressure, okay, which leads to edema. So, sodium retention, we can say excessive salt intake with renal insufficiency, increased tubular reabsorption of sodium, renal hypoperfusion, increased renin-angiotensin-aldosterone secretion. Now come to the last part, which is inflammation. We know in inflammation, vascular permeability is increased, okay, due to some chemical mediators. So fluid comes out of the vessel and edema occurs. Usually inflammation-associated edema is localized to one or few tissues, but in systemic inflammatory states such as sepsis, it can produce widespread endothelial injury. So generalized edema may occur. For example, acute inflammation, chronic inflammation, angiogenesis, etc. Now, here's a figure taken from our Robbins textbook of pathology. So you can see here in heart failure, renal blood flow is decreased. So activation of the renin-angiotensin system and retention of salt, also obligate retention of water. Then blood volume increased, then edema occurs. And in renal failure, retention of sodium and water occurs, the blood volume increased and the fluid comes to the tissue space and it is called edema. Okay, and we can also see capillary hydrostatic pressure is increased in case of heart failure, then also edema occurs. Okay. Another, we can see in malnutrition or nephrotic syndrome, or if some kinds of reason causes hepatic synthesis of albumin reduction, okay, or in protein or plasma protein reduction, then what will happen? Plasma albumin is reduced, so the plasma osmotic pressure is reduced, then finally edema occurs. Okay. So these are the pathophysiologic categories of edema. Actually, there are some other classifications like on the basis of extent of edema. One is localized edema and two generalized edema. And we can just see some example of generalized edema. Edema due to heart failure, edema due to renal cause like renal failure, nephrotic syndrome, acute glomerulonephritis, then edema due to chronic liver disease, edema due to protein energy malnutrition. Just try to remember some of it. Or kwashiorkor. Okay. Then localized edema causes acute inflammatory edema, edema due to venous obstruction, edema due to lymphatic obstruction, and type 1 hypersensitivity edema. Okay. On the basis of nature of edema fluid, we can say there are two types, exudative or inflammatory edema, and second, transudative or non-inflammatory edema. And the basic difference is exudative fluid or exudative edema is protein rich and transudative is protein poor. Okay, so here's a figure This figure shows transitive edema occurs due to increased hydrostatic pressure or low plasma oncotic pressure. That's why low protein can come out of the vessel. So the edema contains low in protein, okay, low protein, and LDH also. For example, congestive heart failure, cirrhosis, nephrotic syndrome, hypoalbuminemia, etc. Then exudative edema occurs due to inflammation and increased capillary permeability. As the capillary permeability is increased, so more protein can come out of the vessel. So the exudative fluid is high in protein. Okay. For example, pneumonia, cancer, TB or tuberculosis, viral infection, some autoimmune disease, etc. Okay. Another classification, clinical classification. One, pitting edema. Second, non-pitting edema. Pitting edema examples are hepatic edema, cardiac edema, renal edema, and non-pitting edema, myxedema, edema due to lymphatic obstruction, etc. This is a figure of myxedema, and it is a non-pitting edema. Okay, and this is a figure of pitting edema. Okay. Now, here's a question for you. What is Anasaka? It's a very common clinical term. Anasaka. So, Anasaka is severe and generalist edema with profound subcutaneous tissue swelling. Okay, and actually, there is an interesting synonymous name of this Anasaka. What is it? This is dropsy. Okay, you have to remember these two names, Anasaka and dropsy. Okay. So this is a figure. We can see here generalist edema, here leg, abdomen, eye, everything is too much soiled. Okay. We are coming to the end of our lecture. Just in the end, here is the quiz for you. A 45 years old woman who works while standing for long periods noticed at the end of her 8-hour shift that her lower legs and feet are swollen, although there was no swelling at the beginning of the day. There is no pain or erythema associated with this swelling. She is otherwise healthy and takes no medications. Laboratory testing reveals normal liver and renal function. Okay. So, which of the following mechanisms best explains this phenomenon? Option A, excessive free water intake. Option B, hypoalbuminemia. Option C, increased hydrostatic pressure. Option D, lymphatic obstruction. So, what is the best answer? So, let's think. Okay, the answer is increased hydrostatic pressure for long time standing. Okay, so that's for all today. Thank you.